I'm Eleni Efstathiou, and in this new COVID era, I'm actually stuck in Houston. So if you see me floating around, it's because a storm is ongoing. And you might hear some guest starring cats or peacocks coming through, so don't pay attention. But more importantly, I'm joined at this eCancer video by colleagues that really don't need any introduction. And of course, so the star of this ESMO has been Dr. Bono, Johann Bono from the UK, Boris Hadaschik, who's also from Europe, from Germany, a urologist, and of course, Nick James, who updated us this year with data from the STAMPEDE trial that I think are quite important for refining the therapy development in prostate cancer. So what we're gathering through Zoom today to actually discuss this data and get there more of an insight and intimate, let's call them, thoughts on the outcomes. And we were discussing before starting how we're going to go about it. So we were thinking of culminating towards the more exciting and trendy new data that came through. So let's start with what we already know. And I will turn first to Nick to give us a little bit of an overview of the refinement of the data of STAMPEDE and what is being offered to us through these analyses, and then get everyone's thoughts. Nick?
Thank you very much. Yeah, pleasure to be here today. So the STAMPEDE data we presented this time was just the metastatic patients in the abiraterone arm. So we've separated out the M0 patients for a separate later pooled analysis with the abiraterone enzalutamide data, probably next year, in the hope that we can potentially nail a survival advantage in the M0 subgroup with the two arms together. For the M1 patients, the thing that's particularly important is what happens in the low risk group, because the latitude trial clearly was confined to the high risk group, which is only around about 40–45% of the total on our own assessments of the STAMPEDE population. So therefore, for regulators and so on, its purchasers, it's important to know whether the benefit is the same in both subgroups. There's no particular reason why you'd expect the biology to be different, but that was the thing we wanted to look at. And that then sits alongside the data with apalutamide and enzalutamide, which are obviously a different class of drug, but show similar magnitude benefits in the same setting. And I think the other thing I'd like to highlight, which we presented at GU ASCO, but it sits alongside the data as Boris is going to talk about, is we did comparative quality of life out to 2 years for the STAMPEDE, abiraterone and docetaxel patients in comparison to ADT. And there's some striking similarities between what we showed at GU ASCO and what Boris showed with the apalutamide data from SPARTAN. So basically, we've got choices now. We've got a lot of agents that prolong survival. They have different characteristics. So one of the ways to choose is between the different side effects and quality of life and so on profiles of these, and also to ensure that they have the same benefit in different subgroups.
So thank you for that, Nick. And I wanted a little bit Johann's comments, because it's actually quite interesting. You brought up a specific point, and we're in a transition of times. First of all, we need to reach the level where our physicians, our community practitioners are actually considering using two rather than just old school ADT, for sure. But we're still in this era, and this is not judging in any way, but it was the era where we would go for a one-fits-all approach. And we're getting used to this, but now with the data that we're seeing in CRPC, we're going to have to transition to a more precise approach to life that's not just about the safety, as you pointed out, and the specific characteristics of the patients, but it's also about the numerator in the therapeutic index, which is the efficacy part. So Johann, how difficult is this transition going to be given where we stand right now?
Well, I think there's many challenges. Clearly, we have to do the trials and show significant benefit for patients. We'll then have to educate pathology labs and ensure, good preservation of tissue and nucleic acids in tissue. And then we have to educate urologists and oncologists regarding how to manage these complex, diseases. And looking not only at interpatient heterogeneity and patient selection for treatments, but also the intrapatient, disease emergence or subclone emergence. When we first developed abiraterone, we reported many years ago that the PI3K pathway was associated with shorter time to progression on abiraterone, a lower response rate. So we've known for a long time that this is a particularly bad subgroup of disease with PTEN loss or PI3K pathway activation. And what the IPATential phase 3 trial has shown is that if we block AKT signaling with an oral TKI, tyrosine kinase inhibitor, in this disease with the AR blockade with abiraterone, we can improve RPFS. Now, there are, many things left to do with this, set of data. But I think what overall these data do indicate is that combined AR-AKT blockade could become a way forward in the future as we move forward. We do have to further refine the predictive biomarker for this trial. I think that there's a lot of potential here. I should say that this class of drugs does have significant side effects. And another key issue would be managing those side effects, particularly diarrhea and skin rash, to a lesser extent, hyperglycemia. And some drugs are more toxic than others. Some of these drugs, can cause significant morbidity. Although I think IPATential, the drug in this trial, is one of the best tolerated AKT inhibitors that I've certainly worked with. So I'm really quite hopeful that this combination will become a way forward for our patients in the future.
And I'm going to come back to this great data that you presented recently, but my main concern, and I'll take it to Boris, who let's say is sitting in the middle and is from a different country. Boris, Nick and the whole STAMPEDE team has mainly brought us into where we need to be in hormone-naive prostate cancer. But still, if you look at the data from the US, we're not using combinatorial strategies as we should. And the use of chemotherapy, Nick, you might have seen the numbers, is less than 5% in this setting. So, and it's really embarrassing. But again, we should not be criticizing. There are a lot of obstacles in community practices. And here comes Johann, who's continually throwing at us wonderful data that's putting us fast forward in the future. But we know from other solid tumors, the uptake is slower, and it might be even slower in prostate cancer. So Boris, how do you see this transition? We're not even catching up with what Nick has taught us till now.
I think it's a concern that I absolutely share. And I think continued medical education and formats like this have to help convince people that earlier treatment and combined intensified treatment really is prolonging life with a good quality of life in the case of now Nick's great data. And so I'm a little bit disappointed that the real world evidence that is out there shows poor uptake. And my personal feeling is that, at least in Germany, we are a little bit more open to intensified first-line treatment. That might be related to cost in different countries, but here we have the opportunity to give both docetaxel and abiraterone and apalutamide, although abiraterone is only approved for the latitude population. So I think the data now is really important to broaden that field, and especially when abiraterone goes generic, I think that is important for the healthcare sector. And I wanted to point out one more thing that Nick did not mention, but I believe is one of the most important data sets, because if you compare the data just presented now to the docetaxel data, the docetaxel curves after initial therapy, they came back together after longer follow-up. Now with abiraterone, we have 6-year follow-up data and the curves stay apart. I think this is so convincing that early intensified treatment is really helpful, and that abiraterone, for example, is a great start. So you have to be extremely ignorant not to offer this to the patients. So I don't know, and I sure hope that it's a issue of generating this kind of real-world evidence data, because I mean at ASCO we had data showing that one AR-targeted agent after the other is as good as chemotherapy after an AR-targeted agent. And I think from an academic perspective, we would disagree and choose to change targets. But I don't know myself what to make of the data. I hope that there are flaws in the generation of this real-world evidence because I don't get it. Yeah.
So Boris, thank you for the comment on docetaxel versus androgen signal inhibition, because I want to round it back to Nick and get his iteration. Because last ESMO, not this year's, last ESMO, we were physically present with Johann and myself sitting next to him when I heard Karim make a comment about the changes with regard to the outcomes as he perceived them. Nick, what's your take? I mean, there were people who put in question the use of chemotherapy for hormone-naive disease, and I'm concerned with that too.
Yeah, so I think there's two separate things really. I think, just going back to what Boris was saying, I think one of the problems I suspect urologists have with giving chemotherapy is that it's outside their comfort zone. They have to send patients somewhere else, not necessarily in Germany, but elsewhere. And so I think having an oral agent that the urologists are familiar with performing just as well is important. I think at the point where we presented our data last year, I thought that docetaxel and abiraterone probably gave similar survival benefits. I think with longer follow-up from those two arms, I think that's probably true for the first few years. I think the curves clearly do come together with docetaxel and clearly don't come together with abiraterone. So it does look, as you get further out, that the benefits diverge. So for the patients who survive longest, they're probably going to do better with an oral agent. For the patients with the bad survival, it probably doesn't matter. Those curves are probably running together. So then you've got to make decisions on other criteria. So cost is one of them. And in the UK at the moment, driven by cost, we can only give docetaxel. But I think the other is things like quality of life. And our quality of life data suggests that your quality of life goes up on abiraterone and down on docetaxel for as long as 2 years from the start. And Boris's apalutamide data looks strikingly similar, and the latitude data looks strikingly similar. And quality of life for me is a really good reason to make a treatment choice. And the treatment choice is in favor of kind of office urology practice as well. So I think particularly having prominent urologists talk about this is a good way to get it into practice everywhere, really. And the biggest gains to be had by applying what we already know to everybody.
So great, thank you for that. And I want to bring up that as you all know, and some people watching us, now abiraterone is generic in the US, and buying a month's worth of abiraterone is $200. So it's become the cheapest of all, as long, of course, as we monitor our patients. And since we're in the topic of androgen signal inhibitors, we saw eventually all the data coming together from all 3 studies in the non-metastatic, conventionally speaking, as Boris, better than anyone, CRPC. So, and the bigger question for some of us remains, even though we saw primary endpoints, secondary endpoints, at the end of the day, this long-term treatment with this agent, what's the impact on quality of life? And I know you're one of the major principal investigators in the SPARTAN study and been involved in the review of the other studies. What are your thoughts?
So thank you, Eleni. Here at ESMO, Stefan Oda presented the updated quality of life data of the SPARTAN trial. And to me, it was very reassuring that we show now with more than double the follow-up, instead of 20 months in the beginning and the first quality of life reports, now we have 52 months of follow-up, and we confirm that despite adding another drug, here apalutamide, but I think it's the same for ENSA and darolutamide in particular, that you maintain good quality of life in this elderly gentlemen who start their therapy in the NM-CRPC space with a very, very high quality of life. So I think there's not a lot of room to improve. When we presented the first quality of life, they showed that our median is higher than the US general population. So these are fit gentlemen, and they maintain their quality of life, although they take one more drug with anti-tumor effect, and they take this drug for, in median, in SPARTAN, 32 months. So this is reassuring, again, that early intensified treatment makes sense. You can prolong life. You certainly generate some cost, but quality of life is maintained And in the placebo arm, there was some deterioration of quality of life starting at 1 year after inclusion in the study. So we see that the androgen receptor targeted agents have good quality of life, and they show that we can prolong overall survival. But certainly if we go further out, we have to individualize therapy more and then start with the other drugs. And I think with that, we can go over to the real highlights of ESMO.
Well, I think that I wanted to also get, usually the UK side of things with regard to the non-metastatic CRPC treatment. And I'm going to go back to Nick before we go into the PROfound study and that final survival analysis. Nick, what are your thoughts on the treatment in non-metastatic CRPC and any qualifiers with regard to these outcomes? Because these were men on trials. Yeah. It's a little different in reality.
So in my practice, these patients have almost entirely disappeared because I'm not at all keen on putting men on ADT for a rising PSA. And obviously NMCRPC is an iatrogenic disease. You create it by putting people on ADT. And you have to be mindful of the fact that ADT harms your quality of life, as shown. It drops in the trial, in the control arm. And it drops because you gain muscle, you gain fat, you lose muscle bulk, your bone density goes, all of these things, you get fatigued, you lose your sex drive, all of these things are bad. And we are, without a doubt, over-treating an awful lot of people. And what I'm seeing in practice is, and my own practice, is that we're tending to track these people and give PET-directed, metastasis-directed radiotherapy where we can. And the minority will relapse with worse looking disease and have to go straight on to long-term ADT, but the majority don't need to go on long-term ADT. So these patients are largely disappearing in most UK practices, I think, and I think they probably should disappear. I think we're over-treating them. And I think the other thing I'm concerned about is that there was a PSA doubling time cutoff to go into the non-metastatic CRPC trials, but I wonder if in practice how tightly that will be adhered to, and people with very slowly creeping up PSAs will find themselves on these agents as well at probably huge cost to the healthcare system and no benefit to the patient.
Nick, you might be more disciplined in the UK, but I can tell you, I just saw this week, a man who, as you called it, iatrogenic, you had to use a Greek word, had not just been exposed to that, but had received back-to-back in 4 months in a physician, abiraterone, enzalutamide, apalutamide, while with exploding disease. I mean, the reality is that, you guys in the UK might be more disciplined, but the rest of us in the world still will have a lot of those instances of. Yeah, go ahead, Boris.
I was going to say, paradoxically, although we often have worse access to drugs than you do in the States, we often have much better access to imaging. So I think we get good access to what you might call fancy imaging, and that I think allows you to make more informed decisions. And if
you have better access to education, I would say as well. Oh, well. Sorry, I just had, it's my belief. Go ahead, Boris.
I cut across Boris, sorry.
No, I completely agree. But I think the education has to be at the time of hormone-sensitive biochemical recurrence. If these men reach castration-resistant in a short PSA doubling time, systemic treatment is the way to go. But I fully agree that at time of hormone-sensitive biochemical recurrence, you have to do good imaging, do a PET then, and discuss with the patient whether you do some kind of targeted therapy to not start ADT, or whether it's a case where you start ADT early, and then you are in an indication where you could consider the hormone-sensitive disease state, adding APA based on the Titan data. So this NMCRPC niche should go away, I fully agree, because if we have better imaging early, we do understand more of the disease, and maybe even we have to sequence this man then very early and then can decide which way to go.
For the time being, though, we should just remember to not put them on autopilot and monitor them while we're treating them. And with that, I'd like to actually go to the exciting data. And Johann, back to you and the PROfound data. It wasn't too exciting to me because we saw the data already presented last year and published, and it was a no-brainer. We were seeing the survival coming as a benefit, even in that interim analysis, and even though there was all this crossover. And to me, it signifies the importance of earlier exposure to agents such as a PARP inhibitor for these specific patients. But walk us a little bit through it and your thoughts for the imminent future.
Well, I think the first thing to say is that when we started this journey, I guess 15 years ago with PARP inhibitors, we from the outset saw anti-tumor activity in breast, ovarian, and prostate cancer. And I still, today in 2020, regret it's taken so long to get where we are in prostate cancer, because as early as 2007, we were seeing responses in men with BRCA2 germline, with single agent olaparib. Nonetheless, through the TOPAR-B trial, we have proven that actually olaparib has single agent activity. But I do want to point out there seems to be a major, negative movement about treating patients with DNA repair defects other than BRCA. And I worry that this is coming from people that have not really treated the patients. And certainly, for the BRCA population of patients, these drugs are highly active with, very durable responses. In fact, the longest time I've given olaparib to a patient is over 11 years with a BRCA ovarian cancer. So, in these BRCA populations, these drugs can work very well. But I do remain convinced that in a subset of ATM loss prostate cancer, from my own experience, these drugs can have impressive single agent activity. But I don't think we've figured out the ATM biomarker well enough to date. And that definitely needs more work. So the trial was a randomized phase 3 study called PROfound, which I designed with our steering committee, 2-to-1 randomization with 2 cohorts. One was the main, primary endpoint cohort with BRCA and ATM alterations. The second was the cohort B, that was an exploratory evaluation of a number of other DNA repair genes, the most important of which is probably PALB2, to a lesser extent RAD51, both uncommon but both important sensitizers to olaparib. And the key thing is that the trial allowed crossover. And this was because after much discussion, we felt it was sensible and ethical to pursue a trial that was open label with crossover at central radiological reviewed progression. So the primary endpoint was rPFS in cohort A based on central radiological review. OS was a secondary endpoint. Because of that crossover, I always had concerns, would we see an overall survival benefit? Now, I am pleased to say that my concerns were unfounded in that in our New England paper that we've just published this weekend concurrently with ESMO, you will see Maha Hussein et al., I'm the last author, a significant overall survival benefit that met the predefined, the pre-specified alpha. The two-sided p-value was 0.02 with a hazard ratio of 0.69. The curves clearly separate for cohort A, which is the BRCA and ATM. Now, let me be very clear. The trial is not powered to look at this gene by gene. And if you start looking at the ATM control arm, it is very small group of patients. So, those individuals are trying to, parse this out to gene by gene. Let's be very clear. There is definitely single agent anti-tumor activity with both olaparib and talazoparib, 2 trials that I've run and led in this disease, single agent activity that can be durable in some patients, over a year with radiological and CTC and PSA responses. But obviously, TOPAR-B PROfound RMA, is a limited patient population. I think with PROfound RMB, I cannot really say that this, in this arm we have any evidence for the overall population of benefit, but I can assure you that there are subsets in there, PALB2, FANK-A, probably as well, RAD51, where we do see benefit. The CDK12 arm is still somewhat, I think fair to say, needing more work. We published in Cell with Arul Chinian leading that work, that CDK12 alterations sensitized to immunotherapy. Work is ongoing in that space. But I think the key thing here is that the main activity for this drug is in the BRCA and some other genes population. Now, this trial pre-specified a sensitivity analysis that the EMA have in the past recommended, using well-described methods to evaluate the survival benefits if crossover had not happened, so to adjust for crossover. And I'll be honest, I have read the papers, I've looked at the analysis. I don't fully understand the statistics, except that it is a recensoring of the data. But you will see that the analysis indicates that there may be an underestimation of the survival benefit because of that very high level of crossover of 2/3 of the patients overall crossed over from the control arm to olaparib, which I think was, in my mind, the right thing to do when we designed this trial. I think it's important to note that even in arm B, we have separation of the curves. There is no evidence of harm to the patients, but there's some evidence of anti-tumor activity for the arm B patients. But the FDA approved this agent for all the DNA repair genes bar one. The EMA have been much more thoughtful. I think that much more conservative. In my opinion, we probably should be best served by being somewhere in the middle. But clearly more research work is needed to further evaluate these subgroups of patients. But I'm proud to say that we now have molecular stratification for prostate cancer with mismatched repair defects, CDK12, BRCA, ATM even, PALB2, and maybe even now P10 with the AKT data. So the dream we all had, to catch up with our breast cancer colleagues is rapidly coming to fruition.
Well, I like that you're always so optimistic, but I think we have ways to go. And I'll go back to Nick with that. We have a lot of ways to go because you're like, as I said, you're moving us fast forward, and potentially these patients who were treated on Profound are what would be the metastatic CRPCL1, not treated with anything else apart from what they were exposed in the hormone naive setting, let's say abiraterone, enzalutamide, apalutamide. And based on the data that's coming from 97, as you pointed out, from Rosie Eels and others, we could see that men who harbored such mutations, especially germline back then, what we could see had the most grim prognosis. So Nick, I don't know if still to this day the UK has updated the guidelines to actually look for germline events, even germline, basic. What's the story, and where are we going with that?
So patients with a strong family history are able to access genetic services in the UK, and that's been well established for a long time.
Cool.
In terms of whether we should be doing it up front, at the moment, none of these mutations allow you to help you select an upfront treatment. You still, essentially, you're selecting on quality of life or funding or whatever grounds, not on any molecular test that says you should have abiraterone or docetaxel or whatever. And I think that we've got analyses underway within STAMPEDE, which hopefully will give us some sort of insight into which subgroups might benefit more from one or the other
That's
drug.
what I wanted to hear, yeah.
So we've got many thousands of blocks pulled in and multiple parallel analyses looking at DNA, RNA, and protein level data for these. So I hope we will be able to provide answers to allow us to select patients up front. Because coming back to Johann's point about breast cancer, and in breast cancer, tumors are classified as whatever, ER positive, ER negative, triple negative, all the rest of it up front. They're not classified on relapse. At the moment, we have good data on how to potentially break out some subsets on relapse, like the BRCA positive ones will benefit from PARP inhibitors, probably from platinums as well. None of that helps us up front yet. Doubtless it will in due course, but we're decades behind the breast cancer doctors in applying molecular classifiers to the initial therapy of men with prostate cancer.
And I'm going to go to Boris with that, because what you mentioned, the family history, I mean, we're way beyond that. We've known this data for 4 years. It has to be any patient with metastatic, and I would argue locally advanced disease. These are the men who are enriched in those first 2 years where you lose patients in your STAMPEDE trial, if we take into consideration a potential non-responsiveness to taxanes based on the docetaxel data that I'm looking back to. So Boris, what's the status in Germany? Are you moving forward towards that level at least? I'm not even talking about somatic NGS. I'm talking about basic germline.
So basic germline, I mean, it's also in Germany hard to get an appointment with a geneticist. So what we establish in our current practice now, given the data that Johann presented, it is that at time of CRPC, so men get intensified therapy at the start, and then at time of CRPC, we try to get molecular pathology on board and then generate the data so that for the next lines of therapy after chemo, we can choose and we can already contact the payers to approve treatment with olaparib, for example. So this is for now our way to go with the patients with a strong family history. There are some initiatives in Germany right now to try to initiate a kind of the Israeli prostate cancer screening trial with MRI and PSA. So when we identify those men earlier on, I think this will lead to more genetic testing and then maybe therapy stratification. But to be honest, in general practice, I'm be happy if we can get a molecular pathology at time of CRPC, but before I don't see it right now.
So it's not happening, but based on the data that was presented last year in the PROfound trial, we could, as early as diagnosis, assess the status and use that moving forward, right, Johann? We don't have to go for like the very exquisite approach of doing biopsying at the time of CRPC. If we can, like in your institutions or mine, sure. But we could go for that archival biopsy right now.
Yeah, and I think we need to work with our pathologists to preserve these diagnostic biopsies better, to get better nucleic acid preservation. And I think once we do that, and this is not going to be costly or difficult, we will get good, genomic data with much less in the way of, screen fails and quality control fails. But no, I agree. We can get these from diagnosis, although it is possible and indeed likely that the diagnostic biopsy will not really truly match the CRPC, genomic data. So there is merit, I think, to our further expanding the study of circulating and CRPC samples, because the diagnostic sample may not really give us all the data.
So, and thank you for that. And in the interest of time, I wanted your thoughts on two more things, Johann, and of course, wrap up opinions from Nick and Boris on that. Before we go to the IPATential trial again, just to speak to that, to the outcomes and what you expect in the future, I wanted to comment on this mini-oral retrospective analysis suggesting, with all the flaws of a retrospective analysis, that you could potentially treat DRD positive patients with cabazitaxel when we have data in the past from Castro et al. And others suggesting that taxanes or docetaxel the right way to go. Because based on the comment you made earlier, I would beg to differ a little bit and say any patient with a DRD positive tumor right now should have the opportunity to be exposed to a PARP inhibitor, and specifically olaparib, since we don't have any other proven efficacy treatment in mCRPC. I was very worried about that mini-oral, and I wanted your thoughts.
I'll be honest, I don't like the terms DRD and HRD. I think that cancer is so complex that we just have to focus on detail. And I think we have to look at each gene, separately, although I do take where you're coming from. Certainly, I think for many, but not all of these DNA repair defects, which is what DRD means, PARP or platinum makes a lot of sense. And don't forget, carboplatin is a good drug. It's well tolerated. And if the patient cannot afford PARP, or PARP is not approved for, say, HCM in Europe, which is quite likely, then I'm giving them carboplatin, and that can work very well.
Okay, I'm going to stop you there because you're preaching to the choir, right? I use it all the time. But Nick, is there data to support it, like prospective data?
So just to, and so I'm not quite sure which question we're answering here, but the thing I would like to comment on is just coming back to something Johann was saying about the archive samples. So we've done some work on this within STAMPEDE. We pulled out samples from our huge archive of varying ages. And what we found was that when we started sequencing them, that the older samples, you lost as many as a third for the reasons Johann said, which is that the samples degrade. What we found when we did it prospectively and aimed to pull the blocks in, because we were scoping out doing a PARP-based trial, and was that the fail rate once you get fresh samples is still paraffin embedded, you know, formalin fixed paraffin embedded, the fail rate drops to just a few percent. So I think that does argue in favor, if we're going to be wanting to look at BRCA or whatever down the line, getting it in the can relatively early rather than waiting until they're castrate refractory 5 years later, when you may be faced with having to rebiopsy because your tissue is now degraded. So I think there's a good reason to do the upfront sequencing, but it doesn't help you with your initial upfront choices, but I think it's worth getting that data in the can.
Sure, and we agree. I was more referring to, and I know Johann's beliefs, and I agree, but honestly, do we have data on platinum that we should use right now instead of going for PARP inhibition?
There's some data. I mean, I think, talking about preaching to the choir, I mean, my experience has been, I suspect, the same as everybody else's, which is that if you give it to a subset of patients will respond well to platinum, and particularly if you know they're BRCA positive. But because it's such a well-tolerated drug, particularly in young, fit men who've had multiple lines of treatment, even unselected, it's worth a trial of therapy. I think, in the absence of the ability to get tested, because you'll see spectacular responses.
Okay, I'll just turn to the German, who's probably more purist, and tell me, do we have prospective data? I use it, and Johann does, but for everyone listening to us, that's all I'm saying.
So we do use it as well, although here in Germany it's a little bit more complicated because we can use this PSMA radioligand therapy very freely as well. So there are now plenty of opportunities for these later disease stages. So we kind of go back and try to squeeze out some molecular data and sit together with our pathologists, and then we decide what to give to the patient. But we do give platinum as well, but I'm not aware of good randomized prospective data. I mean, there's a lot of prospective data that it works, but I'm not aware of good randomized data. So you have to
all we're saying is we need the data, right?
We expect approval of olaparib this year, so then this would certainly be our first choice in this patient population.
Okay, we've completely run out of time, but I want in one sentence, first from Johann, EPATential150. I expected more of a wow difference, and you explained to me earlier a couple of reasons why. Would you like to, in brief, say what you think about the outcomes and how we can improve them in the future?
So I think what we've seen here is a 23% reduction in the risk of progression during the trial for the combination of AR and AKT blockade over AR alone in the PTEN loss population. PTEN loss is defined as 50% of the cells having no PTEN staining by immunohistochemistry. That cutoff was, I think, perhaps too loose a cutoff, not stringent enough. Our phase 2 data looked at essentially an H-score of less than 10, which is minimal staining. The genomic data indicated that there was much more separation of the curves. The hazard ratio then was 0.65. So I think overall we need.
Sorry to interrupt. That was RNA data, right?
That was DNA NGS.
DNA.
NGS for PTEN loss by NGS, but only for a portion of the patients.
That's more stringent, essentially, because you're missing part of.
Right. So bottom line, the combination is superior to the single agent. We need more data, we need more follow-up, and you will need to see, although I have seen it, how we break up PTEN loss by different cutoffs.
So Nick, do you think that this agent is the next one to be approved for MCRPC PTEN loss?
I think there's a little way to go, yes, isn't there? I mean, I think it's highly likely. And there are other agents competing for that slot of the next approval. I mean, like PSMA lutetium is going through registration trials, for example, and will report next year. So I think that will be next. So it's going to get a more and more crowded space. And I think we're going to be segregating the patients up by PSMA uptake, P10 loss, BRCA, and so on, into different treatment tracks, which is great. I think you'll get better choices of therapy rather than just try everything on everyone.
And more precise. Boris, final word.
I fully agree, and I think it's a great opportunity, and we have seen so much progress, and now that we individualize our patient treatment even more, it remains an exciting area, and I'm very optimistic.
Well, on that note, thank you all for giving us your insight, and thank you those of you who are watching us from home or your offices. I hope you enjoyed ESMO. Looking forward to the next one.
In person, hopefully. Yeah.
In Paris too.
Yeah.